do this. Today we are going to discuss about the another topic of neonatology, that is the jaundice in the newborn. It's one of the common problem of the neonate. Although it's most of the time it's a benign condition. It's very common, that is characterized by excessive concentration of bilirubin in the blood. The clinical jaundice affects almost 60% of the full term and 80% of the preterm newborns, with a bilirubin level, significant bilirubin level, that is more than 5 milligram per dl within the first week of life. Mostly the jaundice in newborn is categorized in two categories. One is the unconjugated and or indirect, and the other one is the conjugated or direct. Unconjugated might be physiological, might be pathological, and the direct bilirubin or conjugated hyperbilirubinemia is almost always due to the pathology. What is the normal bilirubin metabolism in newborn? As the hemoglobin mass in newborn is very high, because the fetal hemoglobin has very high affinity for oxygen, so the hemoglobin level in newborn is almost from 18 to 22 gram per dl, and more than 75% of fetal hemoglobin that is unstable once the baby is born, and its breakdown starts. And 1 gram of hemoglobin needs almost 34 milligram of bilirubin. And normal newborn has a load of 18 milligram per dl of bilirubin. This you can see the erythrocytes are hemolyzed and they are taken up by the macrophages, and there is a metabolism, and the hemoglobin is converted into heme and finally into the bilirubin that is conjugated into the liver, and it's once it's conjugated, it's excreted either through the intestine or through the kidneys. And this conjugated bilirubin, once it's conjugated, it will not lead to any serious problem or issue in newborn, because the problem is in neonate is the unconjugated hyperbilirubin that will cross that is fat soluble and crosses the blood-brain barrier. And this conjugated hyperbilirubinemia is not really dangerous because it is water soluble, and most of that is excreted into either through the stool or through the urine. Unconjugated or indirect hyperbilirubinemia might be because of the increased bilirubin production, that is hemolytic, or defective clearance of the bilirubin, or defective conjugation, as it's shown in the previous slides. Either it's due to the increased production, or due to the decreased uptake, or any problem related with conjugation to the liver. So the causes might be physiological. That is the most common cause of indirect hyperbilirubinemia, or it might be physiological. Now you should know about the criteria when to say that jaundice is physiological. The physiological jaundice appear in almost healthy infants. The clinical jaundice appears after 24 hours of life, and the total bilirubin will not rise more than 25 milligram per dl per day. And the peak bilirubin occurs from 3rd to 5th day of life, with a total bilirubin level not more than 12.9 or 13 in term, or 14.9 or 15 in preterm. And the clinical jaundice is resolved in 1 week in term and 2 weeks in preterm. So if there is any one of these is positive, most of the time it's physiological jaundice. But if there is a problem other than this, then it's the pathological jaundice. What happens in pathological jaundice? All the terms now you can say that they are opposite as compared to the physiological jaundice. It may appear on the first day or even after that, and bilirubin level is more than the rising level is more than 0.5 milligram per dl per day per hour or 5 milligram per dl per day. And peak bilirubin is more than 13 in term and 15 in preterm. And direct fraction, as I told you, the pathological is direct is always pathological. There is high pitch cry, increased muscle tone, head retraction, apnea, or might be convergence. The causes might be related with the period of onset, that is early, intermediate, and late. Early is within first 24 hours of life, intermediate is from second day of life up to the second week, and late is after 2 weeks, that persists after more than 2 weeks. Here you can briefly classify the causes of jaundice depending upon the time of onset. Early is because of the hemolytic causes like Rh isomerization, ABO incompatibility, G6P deficiency, or any congenital infection like torch. And intermediate might be due to the physiological jaundice, or breast milk jaundice, sepsis, hemolysis, few syndromes like Rickler-Najar, Gilbert. Polycythemia or bruising may also lead to the hemolysis and ultimately may lead to the jaundice. Late and prolonged is most of the time it's conjugated. And there is dark urine, pale stools, and there might be bile duct obstruction, biliary atresia, neonatal hepatitis, or unconjugated might be the prolonged physiological jaundice, or might be because of the breast milk jaundice, infection, or hypothyroidism. The early jaundice that appears before 24 hours of age, I told you it's always pathological. Then main causes are related with the hemolysis. That might be because of Rh incompatibility, ABO, or G6PD deficiency. What investigations we can send for the bilirubin jaundice, that is serum bilirubin level, full blood count, peripheral blood film, blood group of the baby, blood group of the mother, Coombs test to see the antibodies against the hemolysis, and G6PD level if there is any family history. Here you can see the causes related with the onset. Physiological jaundice, why most of the baby develop the physiological jaundice? As I told you, this is because of the very high concentration of the hemoglobin that will hemolyzed and will lead to the high bilirubin production, and due to the decreased excretion due to the immaturity of the liver enzymes. What are the factors that exacerbate the physiological jaundice? Might be because of prematurity, sepsis, bruising, cephalohematoma, polycythemia, delayed passage of meconium, breastfeeding, certain group, ethnic group, sorry. Neonatal jaundice are prolonged causes, might be because of the prolonged jaundice that persists after 14 days in the term and 21 days in the preterm. There is a randomly we classify the level of bilirubin depending upon the different zones of the body. We divide the body in different zones. That is zone 1, 2, 3, 4, and 5. So depending upon the level of extent of the jaundice, we can roughly estimate that what is the level of serum bilirubin in the body, in the newborn. If this is zone, it's up to the zone 1, it's 100 micromole. Roughly, it's about, if we classify into convert into the milligram, this is almost 5, this is 10, this is 15, 20, and here almost more than 20. Now, conjugated hyperbilirubinemia or direct hyperbilirubin level, we will say that once direct bilirubin level is more than 1.5 to 2 milligram per dl, and are the level of direct traction more than 20% of the total serum bilirubin. And what will happen with the direct hyperbilirubinemia? There will be dark urine and pale stools, because the most of the bilirubin is excreted into the urine. So the color of urine will be dark and the color of stool will be pale, because this due to the obstruction of the bile duct, the bilirubin is not passed into the stool. Biliary atresia, there is a leak place, the bilirubin will not be passed into the stool. Or due to the neonatal hepatitis, there will be problem with excretion. Investigation, I told you, serum bilirubin, conjugated fraction, LFTs, liver profile, coagulation profile to see the function of the liver, ultrasound, different types of scans to see the uptake of the bilirubin, thyroid function test, metabolic screening, hepatitis screening, liver biopsy, full blood count to see the hemolysis, blood group, maternal blood group to see ABO or RH incompatibility, and Coombs test to see the antibodies. One of the most serious complication of the neonatal jaundice is the kernicterus. What happens in kernicterus? It's a neurological syndrome resulting from neurotoxic effects of the unconjugated bilirubin on the basal ganglia and the brainstem nuclei. Though it's infrequent, has almost 10% mortality and 70% morbidity. It will lead to the permanent neurological damage. Here you can see that bilirubin is raised, it crosses to the blood-brain barrier and leads to the dysfunction and death of the neurons and long-term sequelae. In kernicterus, we divide the body or the stages into the phase 1, phase 2, and phase 3. The phase 1 is there will be poor hypotonia and lethargy, and this is the stage where if we will treat the patient will, the symptoms will be resolved, reversible. But once the baby develops in the phase 2 and phase 3, then the symptoms will become irreversible. In phase 2, there is hypertonia and opisthotonus, and in phase 3, there is less hypertonia but high-pitched cry, hearing and visual problems, poor feeding, and choreotype type of movements. The long-term complications are the choreotype type of CP, upward gaze palsy, sensorineural hearing loss, intellectual problems. How we treat the jaundice? The physiological jaundice does not need any type of treatment. Most of the time, it's resolved with passage of time. So there is no need for treatment of the physiological jaundice. But once the level is very high and the risk of problem is there, we treat the patient either by the phototherapy or by the exchange transfusion. Exchange transfusion is indicated once hemoglobin at the birth. If the hemoglobin is less than 12 gram per dl in the cord, it indicates the severe hemolysis, or the serum bilirubin is more than 5 milligram per dl, or the Coombs test is positive, or retic count is very high. If retic count is high, it also shows the hemolysis. In the first week, once the serum bilirubin is more than 2 milligram per dl per hour or more than 10 milligram per day, means if you have done the bilirubin or sent the bilirubin on day 1, then it's more than 10, and it's coming on day 2, it's coming to the reaching up to the 20. It is the it's indication for the exchange transfusion. Any history of previous exchange transfusion, kernicterus or death due to jaundice in SIBS, low birth weight, in the low birth weight bilirubin, even in lower level, we can go for exchange transfusion, or when phototherapy is failing to clear the bilirubin or to fail to prevent the further rise. when to start this therapy. When the level of bilirubin is depending upon the level of bilirubin, rate of rise, gestational age, chronological age, and wellness of the baby. These are the different ways by which we give the food therapy to the baby. There is a certain wavelength which is used for treatment. So at the end, jaundice, any jaundice that appears before 24 hours of life is always pathological. Pancreatitis is rare but serious complication, and early diagnosis of biliary atresia impacts on long-term complication or sequelae. So depends, treatment of the jaundice, as I told you, depends upon the cause, whether it's direct or indirect, and level of bilirubin. We can give either food therapy or extend transplant. In unconjugated, we have to give the more fluid food therapy. Even sometimes we can give the IVIG. We can go for extend transfusion. We can give for phenobarbital to induce the liver enzymes. In conjugate, depend upon the cause. What is the cause? And we have to treat the cause of the bilirubin, hyperbilirubinemia. So thank you very much. It's a simple topic. That's why I have taught you this online lecture. Inshallah, very soon university will be open and we will be again in routine, and our routine lectures will be started, inshallah. Hello, students. Students, hello.
Yes, sir.
Any questions?
Hypothesis sometimes are theory driven. Hypothesis sometimes much from a theory.
Hello.
The theory of reinforcement position that the
Sir, slide share करें.
वो तो होगी नहीं है आप लोगों के पास? That will be shared. Anything else? Thank you so much.
No, sir, thank you.
Positive reinforcement, negative reinforcement. Pediatric patients who are given a reward training going to talk during the sequence, they to be more cooperative during the sequence. They are now regarded yes. The PPD is a directive. Sake and bar. All of the children. Bapak dari school media dan Shah Ele está aqui, karena saya biasa buat school ini. Ya, berbagai video. Significantly remarkable expected to be positive. ठीक है मुझे चाहिए सभी लोग है दे भारत जो लोग है कुछ हाइपोथेसिस थ्योरी कुछ हाइपोथेसिस नाम पूरी ये भी कोई मिसाल suppose that incidence after this situation very kind of lower things and the configuration of the application would be lower using the partial section system then using the partially linked input system. Yeah, no issue. From the end of the solo वही जिनके IV इंजेक्शन लगे वही पेन जिससे कंप्लेंट नीचे लिखे आने लगे ये नाम आने में जीवन सोचे ग्रुप के अपने इनका उन्होंने जैसे पेन जिससे लगे आने चेहरा बदली है इंजेक्शन की तारीफ ठीक है मिसाल यो हाइपोथेसिस पर मुख्य लगो बई कैसे रिस्पांस आगे मिसाल दिया है इन्हें जो मतलब आए तीस सेकंड को इन हाइपोथेसिस जो यो को मतलब 30 सेकंड को ठीक है अल्टरनेटिव एक्सप्लेनेशन ये अल्टरनेटिव एक्सप्लेनेशन है 30 सेकंड को पेशेंट की निजाबती को आई लगी थी या आई लगी थी पेशेंट की निजाबत अपने जो स्कूल के तो ये भी